The thing that is preached by stroke neurologists everywhere and ER doctors everywhere is time is brain. Every minute that passes, that's another 1,000 brain cells that dies, right?
Is I'll see these patients that have come in, they'll have symptoms for 2 days, 3 days, and here they come on the 4th day to the ER looking for help.
The time we can do the most for you is within the first minutes of your stroke symptoms. Call 911, EMS pre-notifies. I think the fastest I've ever given the clot buster is 7 minutes from the time someone arrived at the door, and that's only going to happen with EMS pre-notification. Joint Commission is basically saying that we are doing an excelling job at being a place that if you are having a stroke, we should be the first place you go. If you're in the area where you can get to us versus another hospital within equal amount of time, we are guaranteeing better outcomes on average based on the things we offer when you get here.
Hello and welcome to Pulse Check. My name is Storm Beasley. I'm the stroke and chest pain coordinator here at Carolina Pines. And today we have Dr. Matthew Meier. Appreciate you coming on today. We're going to be talking about stroke, something that we're both very passionate about. So we'll go ahead and get started. Dr. Meier, if you want to kind of give a little background on yourself, let us know about you a little bit.
Sure. Yeah. So I'm Dr. Meier. I'm one of the ER doctors here, assistant director in the ER. And I work closely with Storm here as the ER medical director working with stroke as one of my roles here. My background's that I'm board certified in emergency medicine, and due to a couple of influential cases that I'm sure we'll talk about early on in my career, stroke has always been a big passion of mine. So I'm excited to talk about that today.
Yeah, so let's kind of talk about that stroke background. I believe you said you went to school in Buffalo, right?
Yes. Yep.
So tell me a little bit about.
So I went to school at the University of Buffalo. University of Buffalo houses the Gates Vascular Institute, which was one of the early leaders in thrombectomy through the neurosurgical interventional program there. It was and I actually got to be part of as a ER resident, only the second time a carotid artery was stented as part of a stroke intervention. So a stent plus thrombectomy retrieval. And I got to see that and pretty much things that were first time, second time. It was a pilot site for most of the things that have made it into our guidelines today. The Wake Up Stroke Protocol you see, it was a pilot study site. So these things we'll talk about. I got to be part of seeing kind of work out in the studies, the ones that didn't work out, and see an actual interventional program where I could, go watch the thrombectomy right after a patient got lytics. And it was really influential to my ER practice.
That's kind of one of the things I don't like, that we don't do the thrombectomies here, so you don't really get to see that follow through. But I think that'd be really cool. I think that's eventually coming down the pipeline, we hope. But that's really cool. You got to see the patient from start to finish, and really see the impacts it had. Well, let's kind of go into, for the folks at home, there's really 3 types of strokes. If we wanted to get really, really, really basic level, ischemic stroke, and then hemorrhagic stroke, and then the mini stroke TIA, question. So why don't we kind of just break those down for the people at home, like what those are?
Yeah. So your mini stroke that a lot of people will refer to as a mini stroke, but we know of as TIAs in the medical world are trans ischemic, meaning transient ischemic. So it comes and goes in a period of less than 24 hours. The interesting thing about that one is you may not know that it is a TIA until even the next day, because the symptoms can persist for 23 hours and go away. And if they're less than 24 hours and your stroke imaging is negative, then that meets the definition of a TIA. What that usually is caused by is a brief small clot that resolves itself, whether somebody has a history of AFib and a small clot sent itself into a small vessel. And another spot we see them is areas where the blood vessels meet. So these are our watershed regions. So if you have blood vessels coming from the right side and the left side, and there's an area in the middle that gets the least amount of blood flow, if your blood pressure drops really low briefly, you can have that area suffer from not enough blood flow. But as soon as you restore blood pressure, you restore blood flow. There's no actual stroke, but these are warning shots for strokes. They become most concerning when you have repeated TIAs. We call frequently increasing TIAs a crescendo TIA, and that's very high risk for an impending stroke. Or there can be very low risk TIAs that we never expect to happen again based on your history. So that's kind of your first category. For your hemorrhagic strokes, these are strokes that bleed. They kind of fall into two categories also. You have your hemorrhagic stroke that bleeds because of the stroke, or your hemorrhagic stroke that the bleed really was the stroke. And that can be because you have severe high blood pressure and a blood vessel ruptures and bleeds, or in the case of the brain tissue bleeding, that can be because the stroke damaged the brain tissue so significantly that brain tissue bled. And that would be your hemorrhagic stroke or bleeding stroke. And then your final one, which is the one that we really focus, I think, most of our intervention, what most people think of when they hear a stroke, would be your embolic or thrombotic. This is your stroke that is caused by some type of plaque, clot, or blockage, causing a significant decrease of flow to a region of the brain. And unless that clot is either retrieved, dissolved, or moved on through medical intervention, that part of brain is going to be continued to starve and worsen. And that kind of summarizes, I think, those three areas.
Yeah, no, that was a good job. We kind of talked about a couple things with AFib and low blood pressure. I think we should talk about kind of what puts you at risk for stroke. You know, who is at the highest risk of developing any of these types of stroke?
Yeah, so for risk factors for stroke, different strokes carry different risk factors. So for your hemorrhagic strokes, your biggest risk is going to be high blood pressure. Both severe range high blood pressure when you initially present, but the big thing with high blood pressure, I think a lot of people misunderstand this one. This is important for you when you're in the non-ER setting, and when you're in your primary doctor setting, and when they talk to you about blood pressure control and tight management. You become more at risk for this because your blood pressure is always high, not because it's just high today. You know, you're not going to go from normal blood pressure to just developing high blood pressure to now having a stroke typically. But those blood vessels get really hard the longer the blood pressure is high, and then they don't respond. They're not pliable. You just picture taking like a piece of Play-Doh and leaving it out. You know, if you've had kids and your kids leave the Play-Doh out and then it's hard the next day, that's what your blood vessels, they're supposed to be pliable, and they become like that hard Play-Doh. So what we see is that is what high blood pressure does to those blood vessels that are supposed to regulate blood flow throughout your brain. And that's why high blood pressure is such a significant one. In a acute setting, blood pressure is in the severe range, over 180 systolic, over 110 diastolic. Those can cause two different types of acute strokes. One would be the hemorrhagic stroke from actually a blood vessel rupturing. Then the other common type is something called lacunar infarcts, which are these little small, tiny blood vessels that penetrate into the brain that don't work well when your blood pressure is so high. What we like to see in that case is good long-term control and then keeping you out of that severe range without dropping you too fast. And that's a whole other thing we can talk about. But the other big risk factor, things like AFib, your heart generates little blood clots, and that's why we put you on blood thinners for stroke prevention. And then your other two biggest ones are diabetes and smoking. They're really the same two biggest risk factors for heart attacks and strokes, because they're really two sides of the same coin. A stroke is just a heart attack in the brain for the most part, with the exception of your hemorrhagic stroke. So that smoking history coats your blood vessels with plaques, stiffens them, and those become a way you can have a stroke. And then diabetes, blood sugar, causes vascular disease throughout your body. So the same reason somebody with poorly controlled diabetes has difficulty with circulation to their toes and their fingers and gets more infections, their brain circulation can also be affected.
Yeah, a lot of places call it a brain attack too.
Yep,
Yep. So it's funny. So why don't we kind of walk through what happens when you come to the ER with these stroke-like symptoms? If anybody's spent any amount of time in our hospital, I'm sure they've heard a stroke alert called overhead.
Yep.
You know, so let's talk kind of about that process. I'll take it maybe from like the nurse side,
Sure.
and then like when y'all come in. So anytime someone presents with stroke-like symptoms, you know, one arm weakness, one side of weakness, dizziness, facial numbness, facial droop. The admissions clerk normally call back to the desk in the ER, and that kind of starts the stroke alert process. You'll hear overhead paged, stroke alert, ER room, XYZ. And what that does is that gets a lot of pieces moving. It gets the nurses in the ER getting a room ready, getting a stretcher ready. A nurse is going to get that patient. They go straight to CT to get that imaging, to check for the bleed first. They're trying to figure out when the last time they were known normal, you know, the last time they didn't have these symptoms and somebody saw it, that we can confirm. Once they get back from CT, they get back into a room. There's a whirlwind of things happening. You got nurses probably on both sides of your arms getting 2 IVs. They're getting your blood pressure, your heart rate. They're getting a history from you, probably getting asked the same question 3 or 4 different times because it's just that important to kind of drill down that last known well. But then doc will come in, and then I'll let you kind of take it from there. So, you know, we got 2 IVs, we got your blood pressure, we kind of got the story, and then doc will come in, either sometimes in CT or in the room. But go ahead and take that away.
Yeah, so and that's definitely my preference is to meet them right at the CT scanner, because you know right at that time is when we're trying to decide what type of treatment this is. It's important to realize that there's several different treatments, and we talked about busting the clots, but to do that, you need to make sure there's no bleed, which you talked about with CT. So by responding to the CT scanner and looking right at the CT in real time, we can really quickly determine, okay, this person's not bleeding in the brain, and they might be a candidate for using the clot buster, which is called TNK. The next biggest thing to making that decision is finding out if you're in the timeline. And that's why the one thing I always like to recommend to everyone, even before they come to the ER, and even before they call 911, is if they could still speak, because in a lot of strokes that's affected, to designate someone that can help establish that. So phone number, video call, even if somebody's not there with you, start thinking right away, when did this happen? When was I last normal? And here's the person that could explain it to you. I've even asked people to start a video call and bring that person with you if they can't be. That way we can speak to them, because a lot of times the ambulance will beat them to the hospital, right? That way we can speak to them and establish that. So a lot of times that's what we're doing when we get into the room right after that part you talked about. You're going to get a lot of questions of just, so when's the last time you felt completely like yourself? And that's what we're really trying to find if you're in this window for the clot buster. There's a lot of things required to that. This is the most time sensitive thing we do. So until we know that you aren't a candidate for that, everything is aimed towards figuring that out. And so what you might see is a lot of questions towards, are you on blood thinners? When did this happen? These are all things that are designed to help us know, can you get the TNK, which is the clot buster? And sometimes once we've determined you are or are not, you might see things briefly almost feel like they take a breath, because now we know which path we're on and we can follow that path. So, as a patient, it might seem really hectic while we're trying to decide what path you're on. And then you might see it go a little more, feel a little more smooth once we realize which path you're on.
And so, Dr. Meier, the ER docs also will collaborate with teleneurology through MUSC Charleston. So the neurologists come on the computer screen, and they'll be able to work collaboratively with the ER docs and the ER staff to kind of really help make the best decision for the patient. They'll review those scans too, so there's 2 eyes looking at it. What is that window, for that clot buster? If we can really drill down the last known normal, what is that time frame?
So the simplest answer to that is 4.5 hours.
That's
There's nuances to it, which are in the new guidelines, which we've talked about, and things that you may see coming up the pipeline as far as wake up strokes and things like that, which we're, I think, as a hospital, far ahead of the curve on and already discussing. So, we were discussing these things before the new guidelines came out in January. So I think patients will be surprised to see that we might be talking about these things even before you see them anywhere else. But that 4.5 hours is picked based on a series of large studies that were done that tried to determine how much time the brain could be damaged before it was at risk for bleeding. So a person who has presented within that 4.5 hour window or 3 hour window, if you have a couple of risk factors, we've determined by these studies that there's on average a 1 to 3% risk of bleeding from giving TNK. Beyond that 4.5 hour mark, those numbers vary, and that's why we consider that the end of the safe cutoff without more advanced imaging or techniques. So that's really what we're trying to do with that last known well. And I think sometimes where it's difficult for patients is we really need to know where the first, even smallest stroke symptom started, not when your worst one started. So it's really 4.5 hours from the last time you felt anything that could be attributed to a localizing stroke symptom.
So going into the clot busting medicine, it's not necessarily a miracle medicine where it's just going to reverse it like that. There have been cases where patients are getting better before they get out, the ER, but there are times it takes, days, months. So let's kind of talk about what the medicine does and what kind of the expectation of that when you get the medicine.
The big studies were mostly done with something called TPA because honestly, TNK only joined the guidelines in January, even though we've been using it for as long as I've been in this hospital, because again, I think we've been on the cutting edge here, but it was TPA before. The main difference between the two, just if people aren't familiar, is TNK can be given in one dose. And if something's easy to administer, it's more likely to be done right. And the TPA does the same thing, but it requires stage dosing, which creates more room for error. And that's really why TNK is probably going to show better outcomes, just because less error. And it can be given faster because it's easier to figure out how to give it just in the dosing. So that said, the clot buster, what it's looking to do is to take that clot and start dissolving it. Your body has other ways of preventing the clot from continuing to form. But what these studies really looked at wasn't what happened right in the ER. They were what we call maximum medical recovery at 6 months. So they all looked at the patients the day they presented with the stroke, and then they brought the patients back for evaluation in 6 months. And they compared a pool of patients in a randomized control study that were not given the clot buster and the ones that were. And so really what we know is that there's improvement by 6 months. It's a clinically significant and a statistically significant improvement for people who get the clot buster. So you should not necessarily be discouraged if you don't see those results on day one, because what we know the data shows is you would be better off at 6 months than somebody who didn't get it.
So, it takes time and it's dependent per patient. So something we kind of talked about before we got in here was the other side of the coin after kind of TNK. There's another thing we need to check for. So you want to talk about LVOs or large vessel occlusion?
Yeah. And that's really the holy grail of stroke treatment. And even though we don't do the thrombectomies here, our relationship with MUSC and plus having the tertiary centers, that's kind of the stroke model, is that as a primary stroke center, we are able to identify identify those LVOs and get them to the comprehensive stroke centers that do the thrombectomies quickly. What I will say, is that the patients in the studies that have received thrombectomy, slightly different rules. They can present up to 24 hours. Some sites, this is outside of your specific guidelines, are experimenting with 48 or not even any timeline. They're doing it purely based on imaging. And if there's salvageable brain on the imaging, they're taking you for thrombectomy. And so what we're doing is after you get the clot buster, we're taking you for a second CAT scan. That second CAT scan is looking at your blood vessels, and it's saying, is there a blockage in these blood vessels that's in such a big vessel that waiting for the clot buster to work is not sufficient, that we could do even more for you. And so what we're saying to those people is, if it's one of these three major vessels that splits from your carotid arteries in your brain, so your MCA, your ACA, your posterior circulation, these are just names for major branches. And then they have segments. So you have, your MCA has a first segment, a second segment, a third segment.
That's just where it branches off.
And that's where it branches off, right? It's like how many branches down. And there's different rules as far as how far down the branches they can go to retrieve these things. And the technology hasn't even improved where they reach further than they have even 5 years ago. So, just let's give it as an actual patient example. Someone comes in with a traditional MCA stroke. They're having left-sided facial droop. They're having difficulty speaking. Their left arm is weak. Their left leg is weak. This would be a very debilitating stroke. They're here within the 4.5 hour mark. They get TNK. We're doing a couple things that family may find surprising at first. If they were keeping their blood pressure and parameters differently, whether they got TNK or not TNK, and you may see blood pressures that you're surprised are kept at certain levels. But if we give TNK, we're generally trying to keep the blood pressure from being elevated, and we are sending them back for a CTA, and then we're looking at that CTA for one of these occlusions of the big vessels. And then if we see an occlusion of the big vessel, we're getting right on the phone with one of our comprehensive partners that do thrombectomy, or with our stroke neurologist, or likely all three, and we're making the decision to go in and try to get that clot. How that works is very similar to how a cardiac cath works. The difference is in cardiac, and more people are familiar with this, they're going in and they're opening vessels by placing stents. But with stroke, it's more about getting the clot out. So most of what they're doing is just like a cardiac catheter. They're going in through an artery in your wrist or an artery in your groin, and they're threading up a wire, and they use that wire to find the vessel that has the blockage, and they grab it and they retrieve it and immediately restore blood flow. You can literally see the dye squirted in 30 seconds later, and brain's back in business.
Kind of like snake in the drain.
Exactly.
Yeah. And the little device kind of looks like that too.
It does. It does.
All right. So Dr. Meier, one of the biggest things I see in reviewing, these stroke patients, and it just frustrates me, is I'll see these patients that'll come in, they'll have symptoms for 2 days, 3 days, and here they come on the 4th day to the ER looking for help. And it's just like, man, we could have done so much in that first, 3-4 hours when they noticed it. So, let's kind of talk about how important the time aspect is with stroke.
Yeah. So, the thing that is preached by stroke neurologists everywhere and ER doctors everywhere is time is brain, right? Every minute that passes, that's another 1,000 brain cells that dies, right? So we could see this on an imaging. You can literally watch it mapped in real time, where you just watch the area of the brain that's affected just grow and grow and grow. We want you to come in at whatever point you decide to come in. Don't feel guilty because you didn't come in time and not come. But the time we can do the most for you is within the first minutes of your stroke symptoms. The best chance of you having a complete normal recovery is coming in. Not waiting for that 4.5 hour mark. 5 minutes, 10 minutes. It starts, call 911, EMS pre-notifies, and we're waiting for you. I think the fastest I've ever given the clot buster, which is a medicine called TNK that we give here, which breaks down the clots. The fastest I've ever given it is 7 minutes from the time someone arrived at the door. And that's only going to happen with EMS pre-notification, that it can be that fast. So call 911, get there fast. I promise you, we are all there waiting and rushing and ready to do things as quickly as we can. So the best thing you can do as the patient is just give us a chance to get it done fast.
Absolutely. So Dr. Meier, you had kind of talked about being a primary stroke center, and we just went through our Joint Commission certification to be recognized by them as a primary stroke center. Had a really good survey. They really liked what we were doing, and kind of went to what you were saying, being ahead of the curve with these new guidelines and kind of moving. What does that mean to be a primary stroke center?
So the Joint Commission is basically saying that we are doing excellent, actually an excelling job at being a place that if you are having a stroke, we should be the first place you go. If you're in the area where you can get to us versus another hospital within equal amount of time, we are guaranteeing better outcomes on average based on the things we offer when you get here. This is based a lot on very specific guidelines that were released years ago and just got updated in January. But what makes this interesting for me is we're already doing most of the things on the new guidelines in addition to what was on the old guidelines. So for someone from my background who trained in a comprehensive stroke center that was basically inventing these things that are in the guidelines now. When the interventional neurosurgeon that I work with literally invented some of these thrombectomy procedures. I've seen a lot of stroke treated. I've worked at multiple comprehensive centers here in South Carolina, and coming to Carolina Pines 2 years ago as a primary stroke center and coming to work with you as the ER doc stroke coordinator, I've been amazed at how we are right on the same path as the comprehensive centers. And it's a seamless process to just get all of that initial treatment done. If they need thrombectomy, great. But we talk to these comprehensive centers and they know what we do. If the patient doesn't need thrombectomy, they are more than happy for us to take care of them. They say they take care of them there, they'll do great. We have, this is from the ER right through the inpatient side, all the way through what you do to get rehabbed after a stroke. All of that is, and to prevent another one from happening, all of that is stuff that we do well. We've been recognized. Some of the specific names of the awards escape me now. You probably know better, but I mean, we've gotten accolade after accolade for what we do when somebody comes in.
Well, I mean, and we've been recognized by the American Heart Association. We've been gold stroke elite hospital by American Heart Association. We're also a gold level rural hospital by the American Heart Association, and we have to input data and input these patient cases into that platform, and they hold us to a high standard as well, just like Joint Commission. And like they really attest to the amount of work and care that we're providing for these patients day in, day out, day and night. You being primarily on our night shift, but I mean, it doesn't matter time of the day. They're providing this high level of care to really just expedite the treatment for these people.
So, personally for me, one of the things that I find so rewarding since I started here 2 years ago is, I trained in one of the premier comprehensive stroke centers in the country where a lot of these thrombectomy procedures were invented, where we were part of all the major pilot studies that got us to where the guidelines are today. But coming here to work as a primary stroke center, we are doing things in the same amazing way of how I was trained, but staying agile, right? So guidelines change in January. We're already doing that. Mm-hmm. And, me and you have a conversation and we talk to the right people. And, in months' time, we're going to be updated to the newest guidelines. And these things are not as easy to do at some other places. Carolina Pines really values getting to the best care as quick as possible. Mm-hmm. And they make it easy for us if we have the evidence behind it and the guidelines behind it to do it. And that's been what kept me here. That's why I came out here. And initially I was going to take some part-time shifts here just to kind of help out a small community hospital. And, over time I've come to love it and see how well the hospital does things and how much they care. And, right from the beginning, I was hired to work on stroke with you. Yep. And it's just been amazing to see. It's one of the best experiences I've had in seeing a hospital care about how stroke is treated.
Oh, yeah. And we're very thankful and fortunate to have you. You know, like you said, we've been on this cutting edge, and you know, me personally, I don't want to be left behind. I want to be ahead of the curve. So I think with the leadership that we have here at this hospital and just the dedication to quality, that it really helps us just push these things along. Like I said, we already looked at those guidelines that came out in January, and the only reason we didn't do it sooner is because we were doing the Joint Commission survey, and we couldn't change, you know, until they saw us. So, yeah, with a lot of things that's coming down the line, especially for our rural hospital, I think there's just a big, bright future for stroke. So, what is your window for an LVO, like for us, example, if they were come to our hospital?
Yeah, I think the general accepted rule is 24 hours. I think there are case-by-case exceptions to that even at our hospital because there's room for clinical, but guideline-based it'd be 24 hours. If you're here within 24 hours of a debilitating stroke and we can identify that and find that blockage, we can still send you to have the clot removed. Beyond that time, and I might explain this concept so people understand because they might hear it discussed. There's something called there's two parts of brain within a stroke. There's brain that's already damaged. We call that the core infarct. Infarct is the medical term for when something's been damaged by loss of blood flow. And then we have something we call the penumbra. The penumbra is the area where we could see reduced blood flow. It's at risk for becoming infarct or damaged from not getting blood flow. But in the early part of a stroke, there's a very small area of core infarct, of area that's dead, and a very potentially large area of penumbra. The penumbra is the area you could save. So in an LVO, we might see the whole side of someone's brain as penumbra with a very small core infarct, you know, and if that persists even beyond 24 hours, that might be the exceptions. There's some other exceptions, and this is something I think you mentioned in talking about is, you know, age as a factor, right? We think of ignore it if you're young, and I think that's a good time to bring up the thing that got me into interventional stroke and why cases like this are so important to me. So the case that I had was a patient who was 24 years old. She had just run a marathon. To help her with the marathon, she had drank some of those popular energy drinks that were a little overstocked with caffeine. This was all history no one had when she presented to the ER, mumbling her words. And busy city ER, so hall bed, 24-year-old stumbling through her words, who was a healthy, fit track runner, like nothing triggered for stroke. And this is even at a big comprehensive stroke center. And it was influential to me. I was a resident at the time, and I went and talked to her, and I said, this doesn't seem like she's just drunk in the hall. This is expressive aphasia. She's looking for words and is frustrated that they're not coming out. You know, so I went and grabbed my attending. I said, before I make a big federal case out of this, you know, this seems like expressive aphasia to me. She came over, she said, stroke alert right away. So it turns out what had happened, and this is another common cause of stroke in younger people, not that it's common, but in young people, this is a more common reason for a stroke. She was having what we call a carotid dissection related to high blood pressure surge that occurred from the energy drinks. So this is when a split happens in the wall of your artery. And when that dissection happens, blood gets stuck against the flap and little clots get thrown off. So you don't have to have any risk factors for stroke beyond that. The other one that's common is vertebral dissections, and you could see this from trauma in the back of the neck. There's been some cases with it happening from people who fell off a horse or had some type of big flexion extension injury. And they're missed a lot, especially the posterior ones, because they present with unusual symptoms. But in that case for me at the time, it was only the second time somebody had tried stenting and retrieval in the same stroke. So they stented the carotid for the dissection and retrieved the clots. And I literally watched her entire, it was an M1 segment occlusion. I watched the entire artery open up before my eyes. So that's another reason why if you're young and you have symptoms that are either lateralizing, which that's a way of saying affects one side of your body, or you find speech difficulty, things like that, it's still worth getting checked out.
Absolutely. I think the youngest one I saw working here was 32. So I mean, yeah, it doesn't discriminate, young or old. But I think we need to just kind of, since we're talking about, how age doesn't matter, I think we just need to talk about what the symptoms are. You know, kind of not to go into what you were talking about posterior, but there's an acronym for stroke, and it used to be FAST.
Mm-hmm.
And then they changed it to be fast to catch those
Yep.
posterior symptoms. So why don't we just kind of go through for the folks at home and tell them what signs and symptoms they should be looking for to
Sure.
be concerned for stroke.
Yeah, so your B fast it really is focusing on your fast being the original ones and probably being your most sensitive for your big MCA stroke. But the B added the balance and the eyes. So you will hear a lot of neurologists say blurry vision is not a sign of a stroke, and that's technically in a lot of ways true. But that's more of a clinical determination to be made once you've been assessed, right? So coming to the ER because you have blurry vision and you don't know if that's a stroke symptom is still the right thing to do. It's our job to figure out if you're having a visual field cutoff or discoordination of your eye movements that would be more consistent with a stroke. Where just pure blurry vision usually isn't a traditional stroke, but there's no way at home you're going to assess that. So if your vision feels off, but especially if you notice that you just lost a field of your vision, that means I'm looking at you and everything to the left of me went away or everything to the right. Those are definite signs of stroke. Balance, it is important to know, there's a difference between lightheadedness, and I just needed to take a seat and true balance issues. And I always tell people, think of the balance more like right after you got off of a ride that made you dizzy, and then you're trying to find your bearings again. If you feel that kind of balance issue, that's more concerning for a posterior stroke. Obviously, on the other end of that coin, there's vertigo, which a lot of people understand exists, and that is not a stroke.
And a lot of times it gets wrote off.
And gets written off as vertigo.
If they had a history of vertigo and they don't come for days and they actually had a stroke.
And then they actually had a posterior stroke. And, a lot has been done in the medical literature to, even from our perspective, sir, how can we actually see if somebody's had vertigo or a posterior stroke? It's the hardest one to really determine. And if a trained eye takes a lot of effort to tell the difference, no way you should ignore that at home. And then, going through the rest of the algorithm, it's the things we know, or the rest of the acronym, I should say, one-sided weakness, loss of feeling in one side, and if you notice a change in your speech patterns, the two most common would be people are talking to you and they're speaking normally and you can't understand it, or the reverse happens. You're trying to get words out. They make sense in your head, but then they come out like gibberish. These are two types, or you just can't find the words. Those are typically what we see in stroke.
So we got balance, we got eyes, we have facial droop, we have arm weakness, numbness, tingling. Most of the time it's one-sided. Speech difficulties, and then the T would be time to call 911.
Yep.
Let's kind of talk about the emergency response system
Sure.
with stroke. A lot of the times people say, well, I can drive there faster. And then sometimes that's true, but let's kind of talk about the importance of EMS and stroke recognition.
Yeah, so we always recommend if you think you're having a stroke, you call 911. I mean, there may be a couple small exceptions to that rule, but that by and far is the right choice because that jumpstarts your process way beyond what you driving yourself to the hospital does. For one thing, some of our partners can already start initiating a neurology consult on your way to the hospital, which means instead of making the decision after you get there, and we talked about that core versus penumbra before, say you have a small amount of brain that's been damaged, but all this brain to save, every minute that's changing. So if you can get a stroke neurology consult on your drive in, and we already know we're giving you TNK when you get there, that's a lot of brain saved. And then other things that you might not think about as a patient would be EMS can establish IV access on the way. That saves us a dramatic amount of time when you get there. EMS can pre-notify us, so we're waiting for you. And the EMS, the blood glucose, one of the biggest stroke mimics, right? So one of the big things we do when you come in for a stroke is we have to know your blood sugar, because low blood sugar can mimic a stroke. And by the time EMS gets you, then you know that when you've come through the door. So that's a very important part. And a couple of our partners are utilizing the stroke consults in the ambulance, and it's giving us literally written feedback as they drive in on your progress. So.
And a lot of those patients go straight to the CT scanner.
They do. Yep.
They don't even get in the ER. They come off the ambulance to the CT scanner. We meet them there.
We're entering your information while you're on the CT scanner. And, the other thing is that I do also like to remind people is sometimes I'll do that. I'll meet them. It'll be this whole big thing. And then we get to do the physical exam. I've met them. And because we are trained in this, we might catch early that it is not a stroke. And then they'll say, oh, well, why? They said this, if I follow BFAST, and I want to remind people, this is something so you don't miss a stroke. By nature of that, there should be a lot of people who are not having a stroke caught within that, right? To not miss anyone, that means you're going to catch some people that are not having a stroke. But if it takes a trained medical team, there's still utility to the physical exam. So just because we didn't need always necessarily something fancy to figure it out, a good physical exam sometimes does give us the answers. But in certain strokes, like posterior ones, there's sometimes physical exam findings, but sometimes outside of advanced imaging, you really just can't get to the bottom of it.
Those are the scary ones,
Mm-hmm. Yep.
I always say we cast a big net so we don't miss anything.
Yep, exactly.
I'd much rather, think you're having a stroke for a small amount of time until I can rule it out, and then instead of missing it and not catching it. So
and I'd rather you come in and in 5 minutes be able to determine you have Bell's palsy, which is not a stroke. It's maybe I wouldn't even call it a stroke mimic, but something that is on the BFAST because it's facial droop. But something I can determine in a 5-minute physical exam is not a stroke. But if you try to do that at home and you're at the beginning of an MCA stroke and you ignore it for 6 hours, well, now you've just created a permanent disability that is harder for us to treat, and that's why we'd rather you just come in. It does not hurt my feelings to do a 5-minute physical exam and say, good news, you have Bell's palsy, you're not having a stroke. Because for every person I tell that, I'm looking at the beginning of an MCA stroke too, so that's really what the point of it is.
Yeah, I mean, people got to remember too, we're here to help. We want to do all we can to help. So it's a quick 5-minute exam to rule out a big major medical problem. Perfectly fine.
Perfect. Yep.
So, we talked about BFAST and those signs and symptoms, but I think those are just really big in your face symptoms. I think I've seen some people come in and they say, well, I couldn't hold my coffee cup, this morning, or it kept falling, or, I fell and I bumped my head and I'm here, because I hurt my arm when I fell, but like, why did you fall? So let's kind of talk about, the subtle symptoms and like when they should kind of come in.
Yeah. You mentioned that I dropped my coffee cup. Another one, I went to sign my name.
Yep.
And I couldn't. Yep. I couldn't get
Sign
it to come out
or something.
Yeah, and these are the more subtle things. And I think when you get to the big strokes that we would send you for a clot retrieval for, those symptoms everyone knows. The person whose face is drooping and their whole side is numb. When we get to these more subtle ones that TNK might help, the clot buster, it might be starting something as discoordination, which means you're uncoordinated in your hand. You find that you have your leg dragging when you're walking, and you're like, oh, and you maybe try to put it off. Maybe I'm a little sore. Maybe I got that
bad knee.
I got that bad knee, and that's why. I think the one people miss the most is those more stealthy ones that fall out of your typical MCA symptoms, and these are your ones that affect balance. So if you feel like your coordination or balance just isn't right, it doesn't necessarily have to be in your face spinning dizziness. That actually goes a little more with vertigo. It's actually, we call it an insidious onset. And in medical terms, that means it just kind of sneaks up on you. You're just sitting there and you're like, I feel a little dizzy. I feel a little I went to grab my pen and I hit the table next to it 3 times, you know, and those more subtle ones are actually more likely in a stroke. And then, you know, another one I think is the pure visual strokes. These are your back of your brain that controls your vision. And that tends to be this really subtle where just a little corner of your vision goes out. And that's those. And if you notice that, like I'm looking at you and this area in the upper corner or lower corner just seems to be going out. That's another reason. Don't ignore that and be like, oh, it's just, you know, the sun was really bright today. You know, if it persists, come let us look. We can do a test called confrontation and really easily figure out if you have visual field cuts.
Same with that kind of that coordination, you know,
Yes.
do that finger to nose test.
Yep.
If you're drifting off, you know,
Yeah.
you know that's the problem. So
If somebody were to ask the question like, okay, so I had this symptom, I noticed this kind of vague symptom that's not in my face. I don't want to wait too long where I'm out of the window for intervention, but I don't want to go for something that doesn't make a lot of sense. In general, even for something like a TIA, which is what we talked about, a transient stroke, a small stroke-like event that resolves quickly, you're usually going to see that type of symptom persist for more than 15 minutes. And I think, you know, that's not a hard and fast rule, but if you have one of these symptoms persist consistently, not come and go, but it comes and stays and grows or worsens and it's been going on for 15 minutes and you don't notice it getting any better, I'd start mobilizing my considerations of, all right, is there enough to be worried about a stroke here? And if you notice that that's the case, you kind of review some of these things we talked about and you're finding them, at that point, I would just, you know, play it safe. You may find out it wasn't a stroke and in the future, you now know. We say, okay, for you, this is why this is happening. But that first time, you should always play it safe.
yeah, I mean, it could be like we talked about low blood sugar. You know,
Exactly.
if diabetes is a precursor to it, it might
Yep.
be low blood sugar,
Yep.
and you fix that sugar 15 minutes and it's gone. You can
Exactly.
It's related to the sugar.
Yeah. You know, and a common one we see is Bell's palsy. And like I said, there for me, there's a couple of physical exam symptoms that I can tell. They're subtle though, and I wouldn't have. Once somebody knows, oh, I get Bell's palsy, they'll probably know that and not come the third and fourth time. But the first and second time when it's not familiar to them, I'd much rather you come because for 15 minutes your face has been drooping. Call 911 or come by whatever and vehicle and let me look, and then we can explain, hey, this is how you know it's Bell's palsy. You
Absolutely.
know.
All right. Well, I think we've kind of discussed everything we kind of wanted to talk about. Wrapping up, you know, let's kind of hit some key points we want the people at home to just remember, and kind of gave them a lot of information to process. But if you could just kind of drill it down to maybe 3 points or
Sure.
something to just always remember.
Sure. And I think before I do that, I'll give just a couple pointers on things that I've noticed scare families or patients in the ER the most that maybe I can give them a little reassurance on. So if you are outside of the window where we can give TNK, you will notice that we might allow the blood pressure to stay high. That's on purpose. It's called permissive hypertension. So that's to make the point, just because you're out of the TNK window doesn't mean we can do nothing for you. So even if you waited too long and then you came in and you say, well, they told me if I'm out of the 4.5 window, there are still medical managements that help. One of the things we do is upping your blood pressure to try to push blood through that clot. So people say, you haven't met stroke level blood pressure. No, while they're having a stroke, this is good for them.
Right.
And so still come in.
So what is that, you know, just that high range, just, you know.
So you may see us push it over 180 and that's okay. And we're okay with that.
Right.
So we want it under that and that's the systolic number I'm talking about. And
That's the top number.
And that's a top number. Yeah. So you may see numbers as high as that, which would, I think, normally are when people think of coming to the ER, and you see us do it on purpose, and that's surprising.
Right.
You know, so that's one thing. I think another thing is right at the onset, make sure you have your history partner, whether it's a family member, a friend. You do not know if by the time you get to the hospital, you'll still be able to talk to us. And that's the most devastating scenario where we're trying to get a timeline established and the verbal ability to communicate is gone and there's no one to speak to. So I really do suggest to people, this is what and you can actually see this in some of the guidelines out there. Start a phone call and leave it, if the person can't physically come with you, and leave that phone call connected. And if you show up in the ER and you're not able to speak for yourself, have that person start communicating to us, right over that same phone call.
Well, that kind of, adds to that EMS point.
Yes.
EMS will meet you where you are, and
Yep.
if that family member's there, they're getting that information. They're trained to get for that pre-notification to get that information. And we've even talked about maybe getting stickers of that number and that person and putting it on the patient's chest just in case
Exactly.
it gets lost
Yep.
in translation somewhere. It's there.
Yep.
So, that's that's a great point. And then also too, we need a medical history, because if you're on blood thinners,
Mm-hmm.
you're not say you can't get T and K, but we have to give you medicine beforehand to reverse the blood thinner.
Yep.
So that's important, and that takes time.
Yes. Yep. So, I guess trying to wrap it all up. So, don't be afraid to come just get looked at if you think you're having signs or symptoms of a stroke. It's time sensitive. We're happy to take care of you in the ER, and it's our job to get to the bottom of it, not yours. So, don't be afraid to come in and let us figure it out. Make sure you try to keep your important medical history, like any blood thinners you're on, if you're diabetic, easily accessible, and your emergency contacts updated. That's another important one. When you come to the ER, it might feel really hectic in the first, say, 5 minutes, 10 minutes while we're getting to the bottom of it. But understand it's organized chaos. We know exactly what we're aiming for, what we're trying to do. And when we get you on the right pathway, it'll all kind of calm down and we'll make it clear to you. Understand that stroke presents in different ways. It's not always the stroke we all know of, the facial droop, the arm droop, the leg droop. Stroke is... can be balance. It can be behavior. So if something just seems off, let us figure out if it matches a stroke. And then I think the final thing is to understand in stroke, you want to get to your closest hospital. Do not think because a comprehensive stroke center exists that you should drive a far distance to one. The idea of stroke is getting to that initial TNK is very important.
Time is brain.
Time is brain. So let us do that, and then let us get you there quickly. That's the right thing for you, no matter where. And that's what the comprehensive stroke centers want just as much, that we get that initial treatment started. So, and then if it's not an LVO, you'll stay here and we'll treat you and get you on your path to recovery here.
That was great. I appreciate all the insight you've given us. We really appreciate it. And thank you for watching.
All right, thanks for having me. Appreciate being part of it.
Thanks for listening to Pulse Check. If you enjoyed this episode, be sure to like, follow, subscribe, and share it with someone who might find it helpful. Your support helps this podcast reach more people in our community. Pulse Check is a production of Carolina Pines Regional Medical Center. Special thanks to our producers Hannah Cadell and Anna Tingen. Audio, video, and editing services by Seth and Grayson Johnson at Lockwood Studios. All content is for educational purposes only. We do not intend for the content to be a substitute for professional medical advice, counseling, diagnosis, or treatment. Our content doesn't engage visitors into a professional relationship. We'll see you on the next episode of Pulse Check.